Okay, so the first lecture will be on initiation of mechanical support. Indications for mechanical ventilation when we look at somebody in the down like that. The first thing there is acute respiratory failure. Acute respiratory failure. Now, acute means all of a sudden. All of a sudden they get acidotic. Okay? Well, it's all of a sudden we have to do something right away, all of a sudden. Okay? We can't wait. Because like I said before, acidosis is very bad. Acidosis can cause tissues and organs to die. They can cause more hypoxemia. It can cause cerebral edema. It can cause you to go into cardiac arrest. So it takes about 24 to 48 hours or 48 to 72 hours, depending on the book that you read, for the kidneys to begin to compensate for acidosis. So anytime you have an acute problem, you must react immediately. So how do we define acute respiratory failure? Well, we define that by blood gas values. Blood gas values. So acute respiratory failure means that you have a pH that is less than 7.25. You have CO2 that is greater than 50 and rising. You have PaO2 less than 60 on high level of FiO2. Okay? Or PaO2 is less than the patient's predicted value. Okay? So now, normal PaO2 for anybody will vary slightly because of age. Okay? It's supposed to be that for every 1 year above the age of 60, for every 1 year above the age of 60, PaO2 decreases by 1 millimeter of mercury up to the age of 90. Let me say that again. For every 1 year above the age of 60, PaO2 decreases by 1 millimeter of mercury up to the age of 90. So this is what it means. Normal PaO2 is 90, in the middle. Acceptable range is 80 to 100. So we're in the middle, 90 is normal. So if I'm 61, then my normal PaO2 will be 89. If I'm 62, my normal PaO2 will be 88. If I'm 63, my normal PaO2 will be 87. Okay. If you're 60, your normal PaO2 should be 90. Okay? That's what that means. Any questions about that? Now, this is an example of acute respiratory failure. All of a sudden, pH is 7.21, less than 7.25. CO2 is 65, is greater than 50. PO2 is 50, less than 60, and the backup is 24. Okay, so what we're going to do is to immediately intubate the patient and begin to ventilate them. But I want to tell you something else. You don't really have to wait until pH drops below 7.25 to intubate somebody. Make no mistake about that. If the pH is 7.30, you can intubate them. If the pH is 7.31, you can intubate them. If pH is 7.32, you can intubate them. It depends on the doctor. Okay, so don't wait until, or I don't want you to say, well, the pH is still above 7.25, therefore they are turning into benzene. It doesn't work that way. Okay? So, if somebody is acidic, it means that they are not ventilating. 7.31 is acidosis. So on the exam, let's say that I have a patient that is like this, 7.32, 48, CO2 48. And they go A, nasocannula, 2 liters per minute. B, diuresis patient. C, do nothing. D, intubate and ventilate. Now, look, the bottom line is that they need ventilation, period. That's the bottom line. Because their CO2 is 48. They're acidic. So those 4 options there, the only one there that corresponds with that blood gas will be to intubate and ventilate. So you can say, well, it's still 7.32. No, that's not the way the test goes, All right? So just have that in mind that the pH doesn't have to be less than 7.25 for you to intubate.
What is B?
Huh?
What is B?
B is diuresis. Give them like Lasix to pee. Well, it has nothing to do with this, right? All right? All right, so let me move on here. Uncompensated respiratory acidosis is acute. You're going to intubate and ventilate. Okay? Well, look at this one here. This one here is compensated respiratory acidosis with PaO2 at 61. That's a COPD patient. Now, this is called chronic ventilator failure, or chronic respiratory failure. Okay? Because the patient is compensated and has successfully compensated the blood gas, we don't do anything about that. This is the only compensated blood gas that you don't have to worry about fixing, unless their PaO2 is less than 50, or maybe their O2 saturation is below 90, and you want to fix oxygenation. So my thing is that when the pH is in the acceptable range, the CO2 is high, the bicarb is high, do not intubate, do not increase or decrease ventilation. That's a COPD patient. With that pH being in the acceptable range, that means that that CO2 is a normal range of that patient's CO2. If that blood gas is that way, well, the patient is still acidic. So that lets me know that that CO2 is not the normal CO2 for that patient. We have to blow some of it off and get their pH at least 7.35. 7.35 to 7.39. Then that will make that CO2 about normal for them. So this one here will not be, don't do anything. You have to do something about it. But they're acidotic. But this one here, they have normal acidosis. Okay? Now, look at this one here. his CO2 is 100, the pH is 7.39, you don't do anything. That's CO2 of 100 is normal CO2 for that patient. Okay, so again, when the pH is in the acceptable range, CO2 is high and backup is high, don't put them on the ventilator, don't increase or decrease ventilation. Okay, it's chronic respiratory failure. They live this way. Okay, we don't cure COPD, we don't cure obstructive disease, but we can treat it. Okay. Any questions about this?
Yeah, the PaO2.
PaO2, this one here?
Yes.
That's 60.
Oh, no,
So-
it's okay. Never mind.
Yeah, that would be good, because we said 50 to 65, no more than 70. But now, like I showed you the other day, sometimes they may put O2 saturation there. Okay, so if they go like SaO2, 88%. Well, they have normal PaO2, that's in their range, I agree, but their O2 saturation is not up to 90. 90 and above will be acceptable. So if I wanted to get that patient up to 90%, well, I got 5 more points to go over here. I can make my PaO2 61, 62, 63, 64, 65, and I'll still be okay. So I can increase my FiO2 a little bit to get more PaO2 to increase my O2 saturation. But now, if they don't give me O2 saturation, well, I'll assume that this is okay. It's achieving good oxygen saturation, right? So that 50 to 65, you can increase it all the way to 65 if you need to, okay? Any questions about that? And then this one here is called acute and chronic. A COPD patient all of a sudden had an acute problem. All of a sudden there is a change in what used to be normal for them. Okay, so this one here may be this patient here. 7.38, 75, 60, and then 38. Oh, let's say 35. Now, that's a COPD patient, that's fine. That's good blood gas for this patient. But then all of a sudden they got sick. Their blood gases changed. So that's what we call it acute and chronic. This is chronic. And now they have an acute problem. And then you can see that that now their pH is lower than what it used to be for them. Their CO2 is higher than what it used to be for the patient. Their PaO2 is lower than what it used to be. And then their bicarb is higher because they have more CO2 to compensate for. So that's what we call it acute and chronic. So if you interpret that blood gas, it is partially compensated respiratory acidosis. PaO2 less than 70. Your answer is non-invasive. You cannot intubate this patient. That's not the first intervention. It doesn't mean that down the line you may not have to, but the first intervention is not intubation. The first intervention is BiPAP. So now let's look at this patient here. Let's say that down the line now, I have my patient on the BiPAP. And then 45 minutes later, I got another blood gas. And then I have 7.2, 90, 40, and 42. Is the patient improving? No, they're not improving. So what that means is that the BiPAP is not working. Then you have to intubate the patient. The theory about putting somebody on BiPAP is, once you put them on BiPAP, you get a blood gas 45 minutes to 1 hour later. If the patient is improving, then you leave them on BiPAP and make slight adjustments and leave them there. But if the patient is not improving, you gotta intubate them. That's the way you look at it. So acute and chronic, PaO2 less than 70, first intervention is BiPAP. I don't care what their pH is. When you graduate and go to the hospital, if they want you to put them on the vent, well, that's fine. That's the hospital's protocol. Okay? The way UNM does clinical practice is different from the way Lovelace does it. It's different from the way 2 other hospitals in Florida will do it. Okay, so like I told you now, we have like 415 respiratory care programs now, hospitals everywhere. Okay, so we cannot do it the way that they do it at UNM. What we're teaching you is how everybody is supposed to do it. And that's what MBOC looks for. No matter what school you went to, no matter where you went to your clinical, you're gonna do it this way. Then when you finish, you go to the hospital that you went to work. If they want you to intubate them with CO2 of 40, well, that's fine. That's the hospital's protocol. You do it, okay? So please have that mindset that the exam is a little different. It doesn't mean that it's completely different from the hospital. The reason that they made it that way is because everybody went to different schools. Okay? All right, so intubation and ventilation can take place later if the non-invasive positive pressure ventilation does not improve respiratory care. There's one more before I go to this next item here. There is this one here, 7.30, 80, 85, and 36. That's also acute and chronic. That's a COPD patient. But the problem here is that the COPD patient has too much oxygen. That's different from the one that we looked at. So the first intervention here would not be to put them on BiPAP. It would be to decrease FiO2 or PEEP to lower their PaO2. Because right now, that too much oxygen is causing the patient to slow down their breathing, therefore causing their CO2 to rise. So that is called oxygen-induced hypoventilation. Oxygen-induced hypoventilation. So when we decrease FiO2 or PEEP, we're going to make the patient a little hypoxic. We'll drop their PaO2. Well, when people are hypoxic, they breathe a little faster. So by breathing a little faster, they're going to blow off some of that CO2 and return their CO2, their pH to the normal range. Any questions about that? All right, so that's the blood gases there. So another reason why we may put somebody on the ventilator is what they call respiratory insufficiency. Respiratory insufficiency. So this is where the blood gas values are normal, but the patient doesn't look normal. So the patient is working really hard to maintain those blood gases. Okay? Let me give you an example. you are called to come to the fifth floor and check out the patient that is not breathing well. Upon obtaining the blood gases, you have this result here. Acceptable acid-base balance. But your patient is breathing 40 times a minute. Are you gonna say, oh, well, that's fine, their blood gases are good, so that's it? No, you don't do that. You don't do that. That's called respiratory insufficiency. The patient is working really hard to maintain those blood gases. We cannot abandon the patient to breathe 40 times a minute just because, their blood gases are good. Okay? So what's going to happen to this patient is, as they keep on breathing 40 times a minute, down the line they will get tired. Their respiratory muscles will be tired. As a result of that, they can no longer take deep breaths to get enough carbon to expel CO2. And then they go the other way. Their CO2 eventually will begin to rise when they start slowing down because they're tired. So you may have a doctor that says, well, this patient is breathing 60 times a minute. Let's just go ahead and intubate them. All it means is that the doctor doesn't want to wait until the patient gets tired. Okay. But now, on the test, are you going to do that? Well, no, maybe not. You don't want to do that. You never want to intubate somebody whose CO2 is normal. But that's possible at the hospital. The doctor can say, well, let's just go ahead and do it. Okay, so that's called respiratory insufficiency. Any questions about that?
So what would we do?
Hmm?
What would be expected? Like what should we do for the MBRC?
What you're going to do is you troubleshoot other things like, let's say that they're breathing 6 times a minute. It can be anxiety.
So the same as like what we would do.
Yeah, but one thing you don't want to do is to intubate. Okay, you can't intubate when the CO2 is normal because they are ventilating well. But what I'm saying is that at the hospital, if that patient is breathing 60 times a minute, eventually they are going to get tired. So some doctors may say, well, look, let's just go ahead and do it. Okay? Any questions about that? Now, the next reason is what we call impending respiratory failure. You see it coming, okay? You see respiratory failure coming, and in a few minutes they're gonna knock on your door, okay? Okay, now let's say that there is a wreck out there and somebody got hurt badly, okay? Your legs broken and something like that. They got traumatized. What's going to happen is that they will start producing more CO2 because anytime you have trauma, your metabolic rate increases. If your metabolic rate increases, then that means that you're going to be producing more CO2 than the lungs can remove. See? So you have accumulation of CO2. So we know then that if we don't do anything right away, eventually you're going to go to respiratory failure because you have more CO2 now being produced than your lungs are removed. So what we're going to do then, knowing that eventually you're going to go there anyway, is to intubate you. So anytime a trauma patient comes to the hospital, we intubate them. We don't have to get a blood gases. We don't have to. You just go ahead and intubate them. They are trauma, you intubate them. Because eventually they're going to get there anyway. Okay? That's impending respiratory failure. So please know that blood gases are not the only reason why people get intubated. It's not. Other things, okay? Like what I just told you about trauma. You always intubate a trauma patient when they come in. You don't have to get blood gases to do that. Another thing is like epiglottitis, acute epiglottitis. Yeah, epiglottis is swollen, and if you don't do something, it's going to occlude your airway, and then you don't have any airway. So when we have a patient that has acute epiglottitis, we intubate them right away without any blood gases, because we see respiratory failure coming. We see it coming, right? How about somebody who has a neuromuscular disease? Guillain-Barré, myasthenia gravis, all of a sudden they have an acute problem where they are beginning to get weaker and weaker and weaker and weaker. Their respiratory muscles are going to get weaker and weaker and weaker and weaker. They can't get enough diaphragm in. We can intubate them. We don't need blood gases to do that. What we may need for neuromuscular disease is we need to check their MIP, maximum inspiratory pressure. We give them this manometer. We tell them to suck in, and they go. If they're not creating enough negative pressure, then we know that they are weak. Okay, so for the MIP, normal for people like us would be negative 60 to negative 100. That's the amount of negative pressure that you create when you breathe in. But now, if somebody gets all the way down to negative 20, that would be acceptable. But anything greater than that, like negative 19, negative 18, that will not work. If you get above, it's above because of the unit here. If it's above negative 20, then your muscles are weak. You cannot get good tidal volume to expel CO2, so we got to intubate you. So what we have is like when they come to the hospital, neuromuscular disease patient comes, the doctor, like I said, now they're doing okay, no problem. Their O2 saturation is good, the heart rate is good, they're doing fine. So we're going to monitor them. So what the doctor does is, the doctor may order for the respiratory therapist to go to that patient every 4 hours and check their MIP and their vital capacity. Okay? As long as their MIP is less than negative 20, okay? And their vital capacity is at least 10 mils per kg, we're gonna go over that. We don't do anything. But if the vital capacity drops below this, or the MIP goes above negative 20, we have to intubate them. That's called respiratory mechanics. Respiratory mechanics. So you have to be on the lookout for that. A good MIP and a good vital capacity ensures that the patient has strong respiratory muscles and can cough effectively to clear their airways of secretions if they need to. That's what that means. That's how come if you want to intubate your patient, well, you're going to check your MIP and check your vital capacity to make sure that the patient's respiratory muscles are strong enough to maintain spontaneous breathing. Any questions about that? Okay? Oh, sorry about that. All right, so the next reason why you would want to put somebody on the ventilator is when they're apneic. So the patient has had cardiac arrest or respiratory arrest. both of them go together. If you have respiratory arrest, you're gonna have cardiac arrest. Because the heart needs oxygen. So if you don't have oxygen, it's gonna fail too. So when they have cardiac arrest or respiratory arrest, we're gonna start doing ACLS, okay? And then if we recover the patient, we're gonna intubate the patient and put them on the ventilator. Hypoxemia. Hypoxemia is not a reason to put somebody on the ventilator unless you have tried everything possible to give them more oxygen and then their oxygen is not going up. So in other words, the first intervention for hypoxemia is not to intubate and ventilate. We have a lot of oxygen delivery devices. Now let's say that I have a patient whose PaO2 is 40. PaO2 is 40, which is moderate hypoxemia, and they're on 2 liter nasal cannula. Well, I can make it 3 liters to see if that goes up. I can make it 4. I can make it 5. I can make it 6. Now, when you get to 6, the flow begins to, the flow becomes turbulent. There will be a lot of flow. Then you can go to simple mask. I can put them on simple mask, see if that comes out. If that doesn't work, I can go to Venturi device. Go all the way to 50%. If that doesn't work, I can make it non-partial rebreather. Okay, I can put them on CPAP, which is PEEP. Okay? So I have a lot of options to increase their oxygenation without intubating them. But once you get to PEEP or CPAP 15, I'm very high FIU to get to 60%, and then you start adding PEEP, put them on CPAP because they're still breathing spontaneously at this point. So we're going to call it CPAP. And the patient's PaO2 is not improving, then you're going to intubate them. Because once you intubate them, it's like you're pouring oxygen into their lungs. You're bypassing dead space. You're bypassing all of this. It's going to go in. Okay? So just know that when they're hypoxemic, initially you don't intubate them. You try everything. You know, nasal cannula, partial rebreather, increase the FIU to give them CPAP, and then if they don't do it up to 15 of CPAP, if they don't do it, then you say, okay, now it's time to intubate. Any questions about that? Intubation decreases dead space. You all remember what dead space is, right? Dead space is the amount of volume that doesn't get involved in gas exchange. So everything up here, okay, so if you think about it then, the diameter of the trachea is bigger than the diameter of the ET tube. So the trachea will hold more air here than inside the ET tube. So once you intubate somebody, you decrease their space because not as much air inside that ET tube compared to the trachea. Okay? When their space goes down, oxygenation goes up. Now, let me say it another way too. At any given time, if your CO2 is rising, your PaO2 is going down. If your CO2 is decreasing, your PaO2 is going up. So basically what that means is that if you're going to ventilate well, you're going to oxygenate well. So when you are ventilating well, you're blowing off more CO2, okay? Anytime CO2 goes up, oxygenation goes down, okay? Vice versa. Oh. Objectives of mechanical ventilation supports or manipulates pulmonary gas exchange. Now, ventilators do not cure diseases. It's not the reason why we put people on the ventilator, to cure them of their emphysema or cystic fibrosis. That's not why we're doing that. But when you have a disease process on board, that messes up your ability to oxygenate and ventilate spontaneously because of the disease process. So the reason we put you on the ventilator is that we can manage your oxygenation and ventilation while we are treating the underlying disease that caused you not to be breathing well in the first place. Okay? So it's just managing your ventilation and oxygenation. Once we treat that disease process that is causing the problem, we extubate you. You should do fine. Okay? So it increases alveolar ventilation, that is true. You have more CO2. Maintains alveolar oxygenation, that is true, because you are increasing alveolar ventilation. Increases lung volume, prevents atelectasis. You have to have the right amount of volume each time that you breathe in. If your tidal volume is lower than normal, you're going to develop atelectasis. Okay? It restores functional residual capacity. That's positive pressure. So now, functional residual capacity is the amount of volume left inside the lungs at the end of exhalation. And that is 2,500 milliliters. Well, if my lung unit is collapsed like this, it cannot hold that amount of volume. When we give you positive pressure, we blow it back up like that. And now it can contain 2,500 milliliters. So positive pressure is used to restore functional residual capacity. Putting somebody on the ventilator is all about their A4C. Anytime you lose your A4C, you go on the ventilator. And A4C, if you want to look at it, we have natural PEEP. The PEEP of 5 that we get is what keeps the alveoli open at the end of exhalation so that you can have that amount of volume in there. Okay? So mechanical ventilation is all about A4C. If you don't have your A4C, you're going to be on the ventilator. Okay? And then it reduces work of breathing. If somebody is having a hard time trying to breathe, okay, nothing works, okay, we can put them on the ventilator and decrease their work of breathing and have the ventilator breathe for them. Okay? Now, if you're going to put your patient on the ventilator, initially, you have 4 options of modes. Now, you can do ACVC. You can put them on SIMVVC. You can put them on ACPC. And you can put them on SIMVPC. Any of these 4 modes will work. What is more important though, what will determine what you put your patient on is what parameters did you set on the mode. The mode is not what ventilates the patient. The mode doesn't ventilate. What ventilates the patient is the parameters that you set on the ventilator. Tidal volume, respiratory rate, FiO2, PEEP, all of that. It's not the mode. So if you pick any mode here and you set the right amount of tidal volume, respiratory rate, and all of that, it's going to ventilate the patient. So when you make choices on the exam, you look for a mode, any of these 4 modes, that has the right amount of tidal volume for that patient, the right amount of respiratory rate, the FiO2, the PEEP, all of that. That's what's gonna ventilate the patient. Okay? So there it says that the decision to use ACVC or SIMBVC depends on which one has the appropriate tidal volume and other ventilator parameters. Now, I must tell you that traditionally, we start with volume control mode, ACVC or SIMBVC, but it does not mean that you cannot start with pressure control. It does not mean that. But traditionally, that's what everybody does. You start with volume ventilation. Okay. On the test, you start with whichever one that has the right parameters in it. All right, so we know how to figure out a patient's tidal volume. So you're going to use the ideal body weight in kg. You all know how to do that. Multiply by 6, and then multiply by 8, because normal tidal volume, mechanical tidal volume is 6 to 8 mils per kg. Okay? Now let's say that I got 300 to 600. That's the normal range of a patient's tidal volume. So I need text that giving me, well, put your patient on ACVC of 700 ACVC of 350 ACVC of 400. Well, I'm gonna go, well, the first one, where the tidal volume is out of the range. If I pick that one and put the patient on it, there's more likelihood that I may cause barotrauma. So that one, I'm not gonna worry about it. Well, the next one, 350, well, that's in the range. And then the next one is also in the range, 400, but I have to pick 350 because the higher the tidal volume, the higher the PIP. The higher the PIP, the more risk there is to the patient to developing barotrauma. So we always want to pick the tidal volume at the low end, okay? How do you know, if I started with 350 on that patient, how would I know whether that tidal volume is enough for the patient or not? What would I have to do? Because 400 is still a normal tidal volume for them. Let's say I started the patient on the ventilator right now. I picked that 350, 45 minutes down the line, I will get a blood gas, right? If my CO2 is still greater than 45, then that would mean that this 350 is not enough. I would have to increase it. You can increase it all the way to 60, but you can't, 600, but you can't go above 600. Okay? So always start with the tidal volume that is smaller, or the smallest at the beginning. Okay, so now if you're going to do ACPC or SIMBVC, that's pressure control. On pressure control, we do not set tidal volume. Okay, we set pressure, and the pressure creates the volume. But what level of pressure will I begin with? Okay, you can begin with 20 to 30. Okay, so now if you give me that, first of all, ACPC of 20, ACPC 28, ACPC 35. Well, I look at the first one and go, well, pressure of 20. Well, yeah, that's pretty good. That's in the range. And then I look at the second one. That's 28, but that's more pressure. The more pressure can cause more problems. I'm like, well, no, I'd rather go with 20 because that's too high. And then I go to 35, I'm like, well, that's out of the range, I don't even want to try it. Volume has a direct relationship with pressure on any mode. The more volume, the more pressure, the less volume, the less pressure, period. On any mode. If you want more tidal volume, you're gonna have to set more pressure. If you want more pressure, well, that will yield you more tidal volume. Okay? So for pressure control, you start with any pressure that is between 20 to 30. The lower the pressure above 20, the better off the patient is. Any questions about that? Okay, so I don't have to do this because you know how to do this, right? Yeah, does anybody not remember how to calculate tidal volume for the patient? Because I can do one. Well, let me just do one. In that way, when you take me to court, I will say, well, I did it. Yeah. Let's say that my patient is 60 inches tall. And I'm gonna put them on the ventilator. And I need to calculate the idle volume. So I'm gonna go 50 plus 2 times height greater than 60. Well, I have 50. There are no inches greater than 60. There are exactly 60 inches. So 0 goes in here. So that means that the patient is just 50 kg. And then I multiply 50 by 6, that will give me 300. And multiply by 8, that will give me 400. So the normal range of the tidal volume is 300 to 400. Any tidal volume in that range is normal tidal volume for the patient. But now, when you want to put them on, you pick a number that is closer to 300. And then if you have to, you go up. Okay? We cannot go above 8 mils per kg. And this, right now for this patient, this is the 8 mils per kg. You can't go above that. Because if you go above that, there's more risk for the patient to develop a barotrauma. Respiratory rate, you have to set that. You cannot set tidal volume and not set respiratory rate. I mean, God does not breathe for anybody in the ventilator. The therapist does. All right, so the normal respiratory rate is, what's wrong, Brian? Well, it's true. You know, God doesn't breathe for anybody on the ventilator. The therapist does. All right, so normal respiratory rate is 10 to 20 on the ventilator. You always start with lower number. Like if I'm given a respiratory rate of 12 versus 18, I'm going to pick 12 first. Okay. Remember what I told you the other day? On anything you can think of, tidal volume, respiratory rate, PEEP, medication, anything, you always do it gradually. Gradually going up, gradually coming down. If I have a headache right now, severe headache, well, I cannot take 10 tablets of Tylenol. I can't, right? First of all, I have to try 2. And now if it's still there, then I take 2 more. But you can't start with 10. So it's the same thing, Okay, you go up gradually, and then you come down gradually, on anything you can think of. Okay? We cannot go above 20. We cannot go above 20. Initially, we can't. We cannot go below 10. The only time that your respiratory rate will be less than 10 is when you're weaning the patient. You're turning down the respiratory rate and you want them to start breathing on their own, because as you decrease the respiratory rate on the ventilator, the patient will know that and start breathing more. That's the only time. Okay? But now, if they get to a point where, let's say that the patient has this blood test, that's respiratory acidosis. Well, the patient, now like that 50 kg patient, they are currently on a tidal volume of 400, which is their max. And also a respiratory rate of 20, which is also a max. But they have acidosis. Well, which one are you going to increase? Huh? Yeah, you're better off increasing the respiratory rate than increasing the tidal volume, because more tidal volume will create more pressure that will damage their lungs. Well, this one is just that they're doing it, a few more times a minute. That's all. Okay, so if you get to that point, you will rather increase your respiratory rate above 20 than to increase your tidal volume above 8 meters per kg. FiO2. To begin on the ventilator, you have to have at least FiO2 of 30%, at least. People will not be on room air on the ventilator. Even if they have good PaO2 and 30%, you leave them at 30%. I think that's the lowest you can go on any ventilator. Okay? All right. So you are going to put your patient on the ventilator for the first time. The patient is on room air. They have no history of being on oxygen. You are going to select any FiO2 that is between 40 to 60. That's a magic number. Rule of the thumb, 40 to 60 is what you select. But now, remember, oxygen is a drug. Anytime you take more drug, you have more problems. As a result of that, the lower the FiO2 that you select, the better off the patient is. Like if I'm giving 45% and 50% to place my patient down, well, initially I'm going to pick 45%. Because I know that 50% is more oxygen. Okay? I start with 45%, and then if I have to, I can go to 50. Okay? Patient is on oxygen and or CPAP. Well, if my patient is currently on 60% O2, and now they're going to go on the ventilator, I will also put them on 60%. If they're on 70% oxygen, and now they're going to go on the ventilator, I will put them on 70%. If they're on 100% oxygen, well, I'll put them on 100% oxygen. So you put them on the same FiO2 that they have been on. How about if my patient has CPAP of 15, which is PEEP. CPAP is PEEP. We just call it CPAP because the patient is breathing spontaneously. The patient has been on the FiO2 of 60 and CPAP of 15. Now they're gonna go on the ventilator. Well, I will give them PEEP of 15 and 60%. You put them on the same thing. If they have been on 40% FiO2 CPAP of 5, well, when they go on the ventilator, I'll put them on 40% and PEEP of 5. Any question? These are rules all the time that you need to remember. It's always going to be true. You need to memorize those things, okay? All right, so there are other times that you have to put them on 100%, regardless of what they are on. Initially, you put them on 100%. So I'm going to list, those are emergencies, okay? You put them on 100% anyway. They have cardiac respiratory arrest. With the resuscitation, with the ACLS, the patient has been intubated successfully, and then we're going to put them on the ventilator. You put them on 100%. And then if you have to, you can wean it down, but you start with 100%, because the tissues have gone for a while without adequate oxygen when the patient went down. Number 2, PaO2 in the 40s or below. 40s or below. You put them on 100% initially. Myocardial infarction, heart attack. You know why we get heart attack, right? Because we don't have adequate oxygenated blood going to the myocardium. So we're going to make sure they have 100%. Carboxyhemoglobin. The patient came in, they have CO poisoning, CO poisoning. We intubate them, we're going to put them 100%. The treatment for CO poisoning is 100% oxygen. Near drowning. You have all that water inside the gills. It can't expand, there's no gastric change. We call that thickening of the alveolar capillary membrane. So we need to give them 100%. And now let me see if there's one more missing. Number 6, pulmonary edema. We put them on 100%. Looks like I'm missing one. So that's 6. Okay. So any kind of emergency, you put them on 100%, regardless of what the patient was on. Any questions about FiO2? PEEP. If you're going to put them on the ventilator initially, you do PEEP of 2 to 6. See, like I said, now we have physiological PEEP, what we call physiological PEEP, the amount of PEEP that you're supposed to have, which is 5. So it's not uncommon to use PEEP between 2 to 6 initially. Okay? But again, remember now, if the patient has CPAP of 15, when you put them, you're going to give them PEEP of 15. Okay, that's the only time you will not start with PEEP of 2 to 6. Now, Another thing is that you cannot start somebody initially with a PEEP of 10 or more, unless the patient has been on that level of CPAP. Let's say that my patient is just on 40%, and I'm putting them on the ventilator. Well, I can't give them PEEP of 10, because PEEP therapy begins at 10. If you're gonna put somebody on a PEEP of 10, you have to have a reason to do that. Okay, you look at their lung compliance, you look at their oxygenation, their ventilation, before you increase PEEP to 10. So we just don't intubate them and put them on a PEEP of 10. I mean, you can do it while you're standing there. If I just put my patient on the ventilator, I can go, well, yeah, oxygen is not going up, compliance, no. I can turn it off, because then I have a reason to do that. Okay, but initially you don't. Okay? Anybody do that on the exam? Pressure support ventilation, not selected as initial mode unless set with SIMV. You can set it with SIMV. Pressure support is for spontaneous breathing. What the pressure support does, when you have your patient on pressure support, basically what the patient is doing is sucking air from the ventilator, getting air from the ventilator, opening up the valve over there, getting air. But the patient has ET tube. It's like breathing through a straw. So what the pressure does is, once the ventilator comes on, that pressure moves like that. And this is my ET tube, diameter of my ET tube like that. It does this to the ET tube and hold it there, so that the patient can get more flow without any problem. So pressure support, all it does is to reduce airway resistance, because the more diameter that you have, the lower the airway resistance. That's all it does. It just like that. Enables the patient to get more flow. And then you're going to find out that R1 equals flow times I time. So with pressure support, the higher the pressure support level that you set, the more it does this to the ET tube, the lower the airway resistance. The lower the airway resistance, the more flow that the patient can get from the ventilator. Therefore, their tidal volume will go up. Tidal volume will go up with low airway resistance. That's how pressure support does. Now, if you set pressure support with SIMV, but the patient doesn't have spontaneous breathing, it's just sitting there. It's not doing anything. It is only used when the patient takes their own breath. That's all. To open up that ET tube. Okay? It's not indicated for patients in which control ventilation is desired. That is true. On assist control, you cannot set pressure support. Assist control, whether the patient triggers or the ventilator triggers, they're gonna get the same tidal volume that you set. But it's not always true with SIMV mode. Use during winning. It's a winning mode. It's a winning mode. Winning is gradual withdrawal of mechanical support. Gradual withdrawal of mechanical support. When you intubate somebody and start ventilating them on a full mechanical support mode, they are not using their diaphragm. The diaphragm doesn't contract actively because the ventilator is doing all the breathing. Now, when we get ready to remove the ventilator, the patient from the ventilator, we're going to switch into SIMV, because on the SIMV, the patient can breathe on their own. They can't do that on assist control because it will be the same tidal volume. So now we'll switch into SIMV. They're going to start breathing on their own and trying to strengthen their diaphragm, get stronger, okay? And then we start turning down the rate and having them doing it more. And then we get it very low now, then we can intubate the patient. So that's why we say that it's a winning mode. If your patient is on assist control mode, ACVC, and the doctor comes in while you're doing your bench check and says, well, look, I want this patient to begin to win right now. Basically, the doctor said, well, what the doctor is telling you is switch into SIMB mode. And you start winning them. Okay? Use only for spontaneously breathing patient. When pressure ventilation is to be instituted, the initial setting should be equal to the trans-airway pressure. Yeah. Trans-airway pressure is the difference between your PIP and your plateau. So if a patient is on a volume controlled mode and you do your inspiratory pause, this is what you look at. You see something that looks like this. I don't know if you all remember that. If you do your inspiratory pause, you see that this is your PIP right here. This is your plateau, where it plateaus. So this is what we call the trans-airway pressure. Remember how we calculate airway resistance? Airway resistance is PIP minus plateau divided by flow. So this here gives me an idea of how much airway resistance a patient is going to have. So now, let's say that the difference between my PIP and my plateau is 10. If my flow is 1, then that means that my airway resistance is 10. Okay, so I just told you that the pressure support is used to decrease airway resistance or eliminate airway resistance. If I know that the airway resistance pressure here is 10, and I set my patient up on pressure support of 10, well, basically they won't have any airway resistance. So that's how we determine how much how much pressure support the patient needs. You do your inspiratory pause, you get your plateau pressure, you subtract your plateau pressure from your PIP, the difference will be your beginning point for pressure support. Because you're trying to remove airway resistance. Any questions about that? Peak flow. Peak flow is set beginning 30 to 60. Normal peak flow, some books, like your blue book says 25 to 60. And some books say 30 to 65, that's fine. But the guideline for setting peak flow is your ITE ratio, period. The peak flow controls the ITE ratio on volume control mode. Well, physiological ITE ratio is 1 to 2. Physiological ITE ratio 1 to 2. So any peak flow that gives you ITE ratio of 1 to 2, that's fine. If you're ventilating a COPD, you want to use a longer or a bigger ITE ratio, like 1 to 3, 1 to 4, 1 to 5, because you want to give them more time to exhale so that they're not doing air trapping. Okay, so let's say that I started with a peak flow of 40, and my ITE ratio is 1 to 1 right now. That's inverse ITE ratio, that's where it begins. But I want to make it 1 to 2. Well, what I'm going to do is I will increase my peak flow, let's say to 50. What that does is to shorten my I time, and then lengthens my E time. Okay? If I want to make it 1 to 3, well, I'm going to increase it some more. It will shorten my I time more and lengthen my E time more. Okay? So you use peak flow to adjust ITE ratio on volume control mode. Okay? ITE ratio. Okay? And I've already said this now, if you are going to do a COPD patient, you make sure you have more than the physiologic RTE ratio, 1 to 3, 1 to 4, 1 to 5. An increase in mean airway pressure is desired to improve ventilation and oxygenation. Okay? That is true. Increase in mean airway pressure. Over here, the following will affect RTE ratio on volume controlled mode. Well, that one is easy because what you're going to see right here, if I went I time equals total volume divided by flow. Anytime your I time changes, your E time will change. Okay? So if you look at the formula here, if you increase the total volume, you increase the I time, you shorten your E time, and then you shorten your RTE ratio. By the way, this is a bigger RTE ratio than that. We'll go by the E ratio. If your E ratio is bigger, then you have the bigger, that's the bigger RTE ratio. 1 to 5, that's a bigger RTE ratio because it's got 5. Okay? So now, total volume goes up, I time goes up. If your I time goes up, your E time will shorten. Let's do this here. Here's my I time here. Here's my E time. Okay, so right now I have 1, 2, 3. I'm just using an example. So if this goes up, goes here, well, this here shortens. That's another way to look at it. Anytime you increase your I time, your E time will shorten. And therefore your I to E ratio will shorten. If you lower your I time, your E time will lengthen. Like if I went, instead of here, if I go here, well, this is longer now. And your I to E ratio gets bigger. Okay? Flow affects the I time as well. You can see it there in the formula. The higher the flow, the shorter the I time. The lower the flow, the longer the I time. Okay? Respiratory rate. Respiratory rate affects the total cycle time. The higher the respiratory rate, the smaller the total cycle time. Okay? The lower the respiratory rate, the more the total cycle time. Now see, this is called respiratory pattern. Respiratory pattern, that's what we call this. You have to understand that to run a ventilator. Because ventilator is like once you change something, something else changes. So you have to understand the respiratory pattern. You can't just go to the ventilator and turn down the flow just because you think it's very high. Well, that will affect the patient's I time. Okay? Sensitivity, we've gone over this before. The amount of effort that a patient has to make in order to trigger the ventilator into inspiration. If you're doing pressure, you have 0.5 to -2 is what we call normal. That's optimal. Okay? You said it. But now, if it's lower than 0.5, you may have -0.5, you may have what we call autocycling. Autocycling just means that the ventilator is very, very sensitive. Okay? You can just do this to it, and then it will come on. You can walk by it, and then it come on. You know? So when they tell you that the ventilator is auto-cycling, what would you do about it? What you're going to do about it is to increase your sensitivity. You increase your sensitivity. No, sorry, I think I said that wrong, sorry. You decrease your sensitivity. Correct that. Decreasing sensitivity is making it harder. Increasing sensitivity is making it easier for the patient to trigger it out. Okay? They tell you that the ventilator will not come on, even though the patient is trying to suck in, then you are going to increase your sensitivity. Okay? Now remember, we also have flow sensitivity. Flow sensitivity. Flow sensitivity is the way it works. I think I drew that. At the end of, that's the one I wanted to solve today. At the end of expiration, the ventilator puts out a certain amount of flow in the inspiratory limb of the ventilator. Just push it out like that. And then monitors the flow, that flow that was put out. It will monitor it. So at any given time, if a portion of that flow is missing, right, then the ventilator is going to say that the patient has inhaled a portion of it and is trying to breathe, and therefore it comes on. That's how that's the way it works. It just puts out the flow, it monitors it. Okay? So what we said is the ventilator puts out what they call the best flow. How much flow the ventilator is going to put out? Best flow. And then what we are actually adjusting is the flow trigger. So if I set 1 there, well, what I'm saying is that if the patient sucks out 1 out of whatever that got put out, I want it to stop. If you set it to 2, you're saying, well, if the patient sucks 2 out of what was put out, I want it to stop. So that we're setting positive numbers for flow. All right, we're going to take a break now. We're going to take 25